All right. Well, I'm a pediatric pulmonologist by trade. I'm in Southern California. I have 5 counties that I have to take care of. So people come from 500 miles away. So the whole idea about getting people in and getting them the services that they need, especially it took me, I don't know, 20 years to get down to age 4 with my local sleep labs. Otherwise, I have to go to Los Angeles and then cover me. I'm going to go down to Los Angeles. I'm going to try and make a turn. So it's crazy time. So, but when they asked me to give a talk about polysomnography, I wanted to you guys are I don't know, my ambassadors out there. And really what I'm interested in is as you're in your community, I want you to think about children. And as you're in your community, I want you to think about health equity, about people who can't access it, or their adherence not the greatest for the intervention. So that's where I'm going to concentrate. You have your CEU completion requirements, of course. So there we go. So I just finished a chapter in a book on for dentists, just about dysmorphology and sleep apnea, because they're there. They're seeing the kids, and I want them to think about, let's ask that extra question, not just about cleaning your teeth. So the same when you're at the store. When you look up and you look at the child, and then you look at the parent, you go, we've got 2 people who look a lot alike, and maybe they have similar problems. When we look at the parent, we want you to look down to the child. So I really count on you all as being our ambassadors. We'll talk about health equity and sleep testing, and then just about chronic illness too, because if you're hospital-based at all as a respiratory therapist, I really need you to start thinking about the American Heart Association really making that recommendation that people who are in heart failure in hospitals start getting sleep testing. So for me, if you all have children, and if you have a wife, the wife has come to the pediatrician and says, my baby doesn't sleep through the night. So what are we going to do? The parents complain about this all the time, and really about 25% of kids, it's going to be a problem. So all my pediatricians come to me and, do I need a sleep study in this child? Or they'll order it at Children's Hospital Los Angeles. Patients have to drive 70 miles to go. Gosh, not everybody needs a sleep study, although these annoying mothers of yuppie larvae do get to my pediatricians, and they end up ordering some things. So the things that can really point towards our obstructive sleep apnea are learning and behavioral problems. So these kids who are all, sometimes I think that the teachers should be on the Ritalin and be awake enough to engage their students. But if kids are falling asleep, when I find myself, if I was awake for 72 hours and left the hospital, it was 3 in the morning, and when I got that little knock on my window with a policeman's flashlight saying, you've been really at this stoplight for a couple changes, I think maybe you should. So if the kids are falling asleep in school or they're failing to have attention, it's not necessarily that they need to be on Focalin or anything else. We really need to think about obstructive sleep apnea in those kids. The other is, of course, the dental, but the tonsils and adenoids, especially between age 2 and 6. And some of these kids who have I've got 100-pound 1-year-olds, and it's hard to understand how you can get to that point. But those kids are at very high risk in terms of post-anesthesia recovery. So most of it's adenotonsillar hypertrophy, and you can, if you just open their mouths, you just look for the little uvula. Is it moving up? Okay, the adenoids are probably okay. Are the tonsils kissing? Probably not. Then we have 2, 3, 4, and if they're kissing and their uvula isn't moving when they say they don't bite you in the process. Those kids are the ones who may need a sleep study. In California, they demanded a sleep study prior to doing any surgery, which put a big block because my 2 to 6-year-olds had to go down to Children's Hospital Los Angeles, so Medi-Cal would go, that's 18 months till the next study. This is great. Then as kids get bigger, this will go away, but then I've got 300-pound 14-year-olds, and the sleep apnea is a problem there too. And part of it, you just can't move your diaphragm. I mean, you got 300 pounds. I tell the parents, gosh, when these kids come in and on Sunday morning, they sit on your stomach, I want to watch cartoons, wake up. And you go, get off of me, I can't breathe. They go, well, what do you think is happening when you let your child get to that point as well? So we just want to make sure that you're aware of these additional risk factors. I thought we'd just kind of go through some of the more common problem. So achondroplasia, part of it can it's linked to the brainstem, so you can get some central sleep apnea. But the other is there is more of a problem with the enlarged tonsils and adenoids, and that posterior pharyngeal space. That's a problem. So just taking out the tonsils and adenoids in Down syndrome, achondroplasia, oftentimes you don't have enough space still in the back, and you're going to need to have a CPAP intervention. So we've got almost a third of the kids have already had their upper airway surgery. They've had cranial decompression surgery. Half have abnormal PSG. So again, if that pediatrician or the adult physicians as well, we'll talk about that in a second, aren't paying attention that this is a problem, this is going to be a difficulty. I mean, there's nothing like being shaken 300 times a night while your body is trying to get through the obstructive sleep apnea. Then the effect of the tonsillectomy adenoidectomy is often sufficient. Okay, and there we go. So this is in adults. So just their faces are smaller. The chin can be in, tonsils, adenoids bigger, and so this is just looking at what happens. There's bigger there. So just looking at the sleep Berlin questionnaire, looking at snoring, looking at sleep, looking at falling asleep while driving. Gosh, this is a pretty common kind of problem. So, in your community, please reach out. You don't want to be obnoxious about it, but it's also something that people should be aware of. Prader-Willi syndrome, these kids start eating and don't stop. There's just nothing to keep them from eating. And we're looking at 8 out of 10 kids are going to have obstructive sleep apnea. Now they have, they're neurotypically different. I don't know how else to say it. So their ability, much like that of the Down syndrome kids, they just don't tolerate these things very well. And so you try and do intervention. Feeding intervention doesn't work. They continue to eat. The parents have locked refrigerators, or locking doors, or doing everything they can. And we actually have narcolepsy in these kids. You just go, you fell on the floor again, and we have to get them up. So we do have problems in that respect, and this is where the NIH is continuing to do research, because there's just fewer neurons centrally to fire them off. Okay, Down syndrome. Do you all do sleep studies on Down syndrome kids? And you try and do sleep intervention on Down syndrome kids? Yeah. So do they tolerate the mask? Really, not really. At least in my experience. And there is one vendor next door who feels like they have one that is better tolerated. It's just a nasal. So with those kids, this is, I think Ray Gregg is going to talk about this afternoon, and this is actually doing an intervention at the level of the vagus nerve to try and open up that airway in the back. So again, pretty common, 50 to 100% in terms of Down syndrome. Then preterm birth, we tend to, they had problems in the neonatal ICU. But those kids that are less than 32 weeks, we've got an RSV surge, at least in California. I think it's pretty much nationwide. And those are the kids who are going to get apnea at home. And especially in the face of preterm birth, really makes a difference. We're looking at a vaccine for mothers. So if I can get a mother vaccinated for RSV, then that baby will have about 6 months worth of antibodies, so that we can maybe move away from the synergist. But again, it's tonsils and adenoids, which again, when you're teeny tiny, that's a very high risk surgery, and so we want to aim them towards a children's hospital. The being small for gestational age can add into that risk factor as well. Okay, then craniofacial anomalies. So if you're in the children's hospital, you have the craniofacial anomaly clinics, the cleft lip and palate kids, but these are also the children who, like with Crussons, where they really have a difficulty. So craniofacial cleft will be a problem. They have a retromethia, nasal deformities, so it can be anywhere from something subtle in the posterior pharynx, right up into the palate, up into the lip. So those kids are at increased risk. syndromic things like Pierre-Robin syndrome. I mean, those babies at birth really are in trouble. Stickler syndrome and the like. The craniosynostosis, where the sutures fuse prematurely, they can have midline problems, and again, that will be a problem. And then we've talked about the Down syndrome and achondroplasia. Then we have families, and this is where when you've got an adult in your sleep lab, I got to tell you, the kids are probably the same. So when I see a child, I use the Circle Plus ring, and we'll talk just a little bit about that. This is a way to do home sleep testing with a ring, so the kids tolerate it. I can put it on their toe, and then I go, and then put it on dad. Oh my God, there's some real problems. And dad, put it on mom. She goes, yeah. No, this is where my wife broke my rib. You know, you don't like to see your partner, you know, not breathing, but took a while. So I use a tennis ball. I don't know if you guys use the tennis ball. You just sew it in the back of your shirt, and if you never lay on your back, then that can be helpful, and you can avoid some of that. So when we take a look, when there's that snoring where the cupboards are rattling and drawers are opening and closing like something out of a Disney movie, you can imagine what that whole house sounds like. The other is twins. Also tend to have, if one twin has got obstructive sleep apnea, it's a higher chance that the other twin has it. So there's some heritability in there. Obesity, which is, you know, God bless America. I just had a mom, her son's 14, 300 pounds, and oh, Dr. Landon, he's on a diet. And I go, oh, and how's your diet going too, hon? Oh, I'm only eating 4 bags of French fries at McDonald's. I go, well, do you remember the movie Big with Tom Hanks where he has little baby corn? And let's do that with 8 French fries, because that's equivalent to 1 slice of bread with butter on it. And so if we could just get people to chew their food, if we get the food deserts that occur, where there's just really, you can't find a vegetable. I went to one neighborhood where we had liquor stores, so I brought a barrel and we just put apples in every day. So there's something there besides Takis and, you know, all those bright colors that tell you there's health inside that chip there somewhere. So again, so back to the morphologic conditions as well as obesity running in the family, and then increased incidence. If one twin's got it, the other does too. There we go. And then cerebral palsy. So for my kids, I get a lot of it because I do airway clearance. I have a lot of kids with cerebral palsy and Lennox-Gastaut and all the things that lead to aspiration pneumonia. But if you do a pediatric sleep questionnaire, if you talk to those parents, especially with my sicker kids, they go, yeah, this sleep time is not good. We don't get much relief for them, caring for them every day. So I have a mother, let's see, Hector is 28, and he eats at 6, and again at 10, and then he has to have a bowel movement at 11, and then he gets up at 3 in the morning, and his mother hasn't slept in probably 3 or 4 years, I don't think. So they've got all this equipment for my airway clearance in a teeny tiny little bathroom, so you have to pick him up. So the caring for the children who are chronically ill, we really also have to look at the parents in terms of their own health. So just the pediatric sleep questionnaire really suggests in about 2 out of 3 kids, we've got some kind of sleep problem, if not just for the patient, also for the family. And then my friends with muscular dystrophy and other neuromuscular disorders. So we look at peak cough flow, and as that goes down, especially in kids below 160, adults below 270, really they have an insufficient cough. So they're and so this is where the intervention with all the devices that we've come up with make a difference. And so but a little cold will put them over the edge. Doesn't take much in terms of the pooling of the respiratory secretions in the valleculae. There suddenly they're and then onset of sleep disorder breathing, as well as pneumonia and hospitalization. And each of those hospitalizations, they don't regain all their pulmonary function back, much like in cystic fibrosis. We see this swirling towards the drain. So I'm very aggressive with that. And then if they're in hospital and you're taking care of them as respiratory therapists in hospital, all those HP monitors are really sleep monitors. I mean, you just have to record, hit the record button, have someone take a look at it. But it doesn't take much. And if shift by shift, you can encourage people to take a look, that makes a difference. Okay, and then spina bifida myelomeningocele. So they oftentimes will have increased intracranial pressure, need to have the shunts put in. But if we take a look, and because of the lack of activity, oftentimes we get difficulty with exercise, difficulty with walking. We'll end up with exogenous obesity as well. So we're looking at obstructive sleep apnea, 20–30% of the population. So if you have a patient, and these are relatively rare pediatric conditions, but you all are in the forefront, and if you can just help them a little bit to realize that this is a risk. So obesity, the increased intracranial pressure, and just an increased incidence of obstructive sleep apnea in spina bifida. And then the mucopolysaccharidosis. So all those at Notre Dame, you see the creatures there. That's Hunter-Hurler syndrome, and so with that, again, 95% of them have problems with sleep apnea. They have big livers. They've got difficulties moving the diaphragm, our nice biggest muscle in the body. So with the airway obstruction, obstructive sleep apnea, it can be adenotonsillar hypertrophy too, because they'll get the mucopolysaccharides in their tonsils as well. So they'll improve with that. There we go. And then orthodontic. That's why I got to write the chapter in the book to dentists. So when if you have children, it seems like they want to put braces on 3-year-olds as the teeth start coming out. But this, when they talk about needing to advance palates and you really also need to look at that obstructive sleep apnea as well. So the malocclusion is a real problem, and up to 90% of the kids can also be having difficulties with sleep. And that's where asking the questions about school and other behavioral issues can be helpful. So overbite, posterior crossbite, all those will add into problems with obstructive sleep apnea. So this is, I'm not sure if you guys are going to get a copy of our slides. You're welcome to contact me, but that's just all that in one table to get out to your people. So where do you all practice? Do you practice in big cities, small cities, little towns? Teeny tiny little towns? Yeah. So I'm in Southern California, so we have a lot of farm workers. In parts of LA, we have large black populations. And this is a different culture. We have Mixteco. These are farm workers, and there's around Oaxaca, there's just drought all the time, so they would all come to the United States, and they're short, so they call them Oaxacacitas, and a lot of discrimination in schools. They come to school, they don't speak English, they don't speak Spanish, so everybody gets to beat them up. And so when I look at my community, I really need to learn to speak Mixteco. I can't. I've sent people down. That's a really hard language. Plus, culturally, there's a valley Mixteco, there's the mountain Mixteco, and there's the coastal. And so I'll bring in a translator, and I'll go, "How are you today?" And there'll be a 30-minute exchange between the patient, and it turns out one's coastal and one's valley, and they're just fighting about whatever went on centuries ago. So, so anyway, so just in terms of health equity, this is just kind of a general, how does all this intersect with obstructive? If I'm in a neighborhood, and do we give priority to green spaces in inner city? Well, not really, which means I'm not walking. I have asthma camps, and look at the patients in Oxnard, California, and I go, my gosh, I've got all this asthma right in this one neighborhood. And so I go, okay, well, let's compare that to violent crime. Oh, the two maps intersect exactly. So I had an asthma camp, and I had some of the kids in the car, and one was late, and he had 5 baseball caps. As we went through Oxnard, every couple blocks he had to change the cap because the Mickey D boys didn't like the 5th Street guys, didn't like the... So there's all that, but it also means now I've got more obstructive sleep apnea just due to allergies, just the house dust mite and mold and cats or dogs and cigarette smoking. So I've got all those problems and where to walk. We ended up in La Colonia walking with the police in front of us. And so I had 100 people, and so we walked through. That was fine. Then I went to Ventura Avenue, and I said we did local treat it as its own village. And I said, could you draw me a map of where you walk? And boy, it went around because now I know where all the drug dealer houses are. And so yes, we can safely walk. So we've got just decreased physical activity, decreased green spaces, insurance coverage. We have medical. Can't assign everybody up, but we have decreased access to health care, particularly among those who are not who are farm workers and are not here with papers. And then just systemic racism. I mean, just people, if I don't have a racism that's just built in, being racially, culturally, opposed to being really aware of someone else's culture and how the family eats and what the holidays are and so forth. And then we've got downtown Los Angeles, Goodyear plant was, and horrible asthma just from the fumes. And so with that, again, comes more problems with obstructive system. Then light and noise. Visit my house. I live where all the lights go out at 10, so you can see the beautiful stars. And he said, I can't sleep. I go, I'm sorry. Why can't you sleep? He goes, we're quiet here. What the heck? So you get a lot of noise and light there too. Let's see, access to care, and then all the family factors, how parents interact with your children. Experience screening, and this is looking at it. Actually, I score high on the test. This is have you ever been hit? Was your mother on drugs? These are not questions generally my pediatricians want to ask. Have your parents ever been in prison? Was there a divorce in the house? And so I've been at this for a long time, and I started going, oh, I see, my mother was in prison in Guatemala. Hey, I score pretty high. So adverse childhood experiences add in. So the family factor, family structure, family stress, all these are going to give more problem. And then just resources. We were just in Georgia, and it was hysterical. So we went out, beds for kids. These kids are sleeping on the floor, and so we worked with a local nonprofit there to get beds for kids. Every single one of those kids had a cell phone. No bed, but they had a cell phone. So just having a place you can sleep that's comfortable, household income, and then just all the individual factors, race and ethnicity, immigrant refugee status, discrimination, temperament, biology, mental health, just all lead into poor sleep health. Now, I came here in a red eye, so if I'm kind of moving around a little bit, I think I didn't go to sleep while I was talking to you yet, but just so sleep deprivation will add in to everything that goes on. So what can we do in our communities to improve sleep health? So we kind of break it down into the ecology, things that contribute to the sleep disparities. There's a health disparity, and then how can we solve these things? So just looking, so individual family levels, well, we got to address those language and cultural barriers. We need to be culturally aware. We need to get those sleep-specific resources. I had a public health nurse come in and said, Dr. Landon, I'm going to report this family for child abuse. And it's a Mistako family. They had 18 people living in a two-room place. They had 8 refrigerators. older people were working, the young men were sleeping on couches, and there was beer everywhere. And this child, and that's just, so he wouldn't move, wouldn't make noise. Is that abuse? How does that fit in? And for them, that's what needed to occur. And then just perceived discrimination. I think we're seeing that with Kanye West, I guess. Yeah. Anyway, so, and then when you're educating your patients in their language, that's so important in terms of language and being culturally appropriate. So you all know the Chevy Nova problem. So in South America, they're trying to sell the Chevy Nova, and Nova means no va, doesn't go. So it wasn't a big seller. So these how things with language makes a difference. The beds and bedding. So I need a comfortable place to sleep. I need it to be at a proper temperature. I need to get sleep promotion going in my community. And then, this stupid our knowledge of the entire world is 3 inches from your face at 3 in the morning. Taking those cell phones away at 9 o'clock in whatever way you can. I had, where were they from? South Korea. I had a film crew come in, and they said, Dr. Landon, tell us what you think about cell phones, and I have certain opinions. And they showed me the stroller that had the cell phone built in. So right at birth, as they're going, boom, cell phones are part of their lives. And so, where was I? Oh, I was in Belize a couple months ago. No kid had a cell phone. They were hooped along with sticks and throwing stones at each other and building things and, being kids. So this access to mobile phones isn't in my favor. Have you tried the sleep apps? Yeah, so I think I'm not really impressed. By about 3 months out, you might have 100 people download it, and by 3 months out, maybe 12 people are still using it. But if they find it effective, that's great. Okay, and then neighborhoods, parks, swimming pools, places for kids to play and get tired so they get a good night's sleep. So just improving urban planning. And we had a CDC grant for Ventura Avenue, trying to get that up and going. Access to care. If you're in a small town, do you have someone aware and someone who? I was just in Belize, and they had a defibrillator that they got from the Rotary, and of course the batteries didn't work. They hadn't replaced the batteries in 10 years, but getting really the care and access to care and transportation to care. I'm a transportation system, so I go, wow, let's see where the kids are. Oh, they're in school. So I bought a mobile van. We just bring the care to them so that we can get what they need with educated doctors. So, is that why it's cutting in and out? I'm a bad boy. Sorry, I'm better now. Okay. So, do you all do home sleep apnea testing? Yeah, you have to. Now, again, I can do a full sleep study on this ring. And so that's really what I'm looking for, is to get it as the functionality, at least do screening so I can get things done at home, and so I can follow my kids after they've had their tonsils out or after they've had their cleft lip and palate surgery, because there's a rebound about a month out. My kids with Down syndrome who've had their tonsils out, that we get a rebound problem. So I need some way to look at sleep at home. And what I tell my patients is, if I look in your windows at night to see how you're doing, you call the police, have to wear that stupid ankle bracelet again, can't go around elementary schools. So I need some way to look in there. And we were just at Aging 2.0. And my daughter, I'm at an age where my daughter would like to know I'm okay and I haven't fallen on the floor, don't have a broken hip. But I don't want the cameras at me, so we're looking at some heat cameras. Maybe that's a better way to go. We've used electronic dust, just so I can find out where grandma is. And we work with Europe, and just making sure that grandma can't turn on the burners when we don't want them on, and the microwave doesn't go for 99 minutes and explode her oatmeal everywhere. So we need some way to look in the home, and that's where I really like home sleep apnea testing. And I'd like somebody to be able to interpret it too. So if that's in your bailiwick, for heaven's sakes, do it. I know you need to have a doctor right at the bottom, and he gets a little funding, but it's really important. And then what's moved in, I've been at telemedicine since 1969, trying to move a chest X-ray from Alaska down to the Stanford Artificial Intelligence Center over this little 2 kilobyte per second line, which is like sucking an elephant through a straw. But pixel by pixel, we were able to get something going. So I've been at this. We were the first Blue Cross telemedicine center for California. That was in 1989. And then our cystic fibrosis clinic, I had enough adults that we wanted to get a full adult clinic, but that was 30 miles away. So we started looking at Zoom and Skype and all those, and how can we do that with HIPAA. And then this thing called COVID hit. I don't know if you've heard of it. And all of a sudden, 130 CF centers wanted to know how we were doing it. And so telemedicine makes a big difference. And for my patients, most of my follow-up visits are by telemedicine. But that's where, and I'll give out, I have probably 10 of these rings in my office. That's where I'll give out the ring. They can upload the PDF. I can see how they're doing, put it in their medical record. But also I can take a look at their house. And I have one, let's see, the camera was here, wall was here, and grandma was smoking on the other side of the wall, but I could see the smoke, or the cat's tail coming by. So being able to, with permission, get into their home and taking a better look. And then who is it who's providing care? We really want to make certain that in those neighborhoods that we have people who really want to be there, who want to provide care. And so this is where training primary care physicians in sleep. And we have a family medicine residency, so I have, how many served? Let's see, 30 times 14. So I don't know, I have about 1,000 family medicine residents out there, and I teach pediatric advanced life support. And they'll just say, every once in a while they'll go, Dr. Landon, thank you, we saved a life. And I go, okay, well that was worth it. So just educating them about sleep. And then redlining of neighborhoods in terms of segregation, and then access to care, and making sure they have access to sleep-related services. Now things go, I think Tennessee, thanks to the Gants, is pretty aware of what needs to occur, but there's a lot of stuff, like they have 10 care in Tennessee, and North Dakota they have no care, so these things all vary. So if we take a look just in disparities in non-whites, may be more prevalent, but it's more severe by the time it gets there. And Social Security depends on a decreased lifespan for men of color. They depend on them never being able to cash that in, because they're going to have congestive heart failure, they're going to have a heart attack, they're going to have problems with obstructive sleep, they're going to be shot, anything to, so it makes me a little crazy. So it's going to be underdiagnosed because they're not having access to care to people who are aware. They did a Hispanic community health study, and 14% had apnea-hypopnea index greater than 15. Now, I run greater than 10 most nights. I don't run 30, except if I haven't been asleep for 3 days. But of those in that Hispanic study, only 1% had a clinical diagnosis where somebody even asked the questions that needed to be asked. And then the Jackson Heart study, 24% had apnea-hypopnea index greater than 15, only 5% of physician diagnosis. So doctors need to know, but I need all my ambassadors of sleep health making everyone aware. Now the other, we have enough, my compliance rate in kids with intervention at home, probably runs 75, 70%, because I'm pretty aggressive. In my adults, so the parents, I got, gosh, maybe 40% adherence. I got a lot of CPAP machines sitting in closets. Oh, it's too noisy. It's too this. It's too that. I go, well, so, what can I do? Well, again, we need to have some kind of trust in the medical system. The doctor told me to do this, or he's not giving me access because of this sense. So we've got other things to do. When my patients don't show up, why didn't you come? I mean, they schedule 17 one-hour consults for me a day, so I kind of pray that some people don't show up. But it's, oh, my next door neighbor's having a fight. Oh, the battery didn't work in my car. So there's a lot of problems with accessing care, and there's just competing burdens. How do I get food on the table, along with adherence, and just there's shorter sleep. We've got a noisy city, a light-filled city. It's more irregular, so it makes adherence more difficult. It's not that you're going at 9 o'clock, time to put in my sleep. We've got other things going on. And then just interaction, getting my patients in and trusting the system. So what are we going to do? Well, we need to give more access to care, and that's geographic. We've got to get the functional barriers, the transportation down, and hopefully maybe some telemedicine will help with some of that. But the main thing is we've got to empower non-sleep practitioners. So the docs who are certified in sleep, about all I find them doing is just signing off sleep reports. They're not aggressive in the community, and that's really what I need. And as with my family medicine residents, I need every doctor to include this. Now their insurance or their whoever's hired them, their whatever healthcare system. Oh, well, you've got 3.2 minutes, and I want you to talk about sex, death, drugs, rock and roll, take care of all their problems, talk about get their ADHD, everything fixed. So you need that extra time to do that. So primary care, in terms of adherence, it's better if your family medicine doctor prescribes it rather than going to the sleep specialist. Having nurses follow up is better than having sleep specialists. The sleep education is better from the nurses than it is from the doctors. So one of my doctors said, I said, oh, and what do you do about sex education? Because you don't have much time. He says, 3 words, don't do it. Okay, that's really not what education. So this use of nurse practitioners, physicians, assistants, hopefully the way the system's supposed to work, they're spending that extra time. And then just if we can get those things done, we'll get better adherence to what's needed. Now the other is peer buddies. And so what was I trying to do? Obesity. We had a grant with Aetna, and they had a pager that would go off and say, it's time for your church picnic, and have the turkey, stay away from the sausage. And they're like, it annoyed me so much, it took me about 15 minutes before I wanted to throw it in the toilet and flush it down. But peer-to-peer, through church, through social activities, this is really what we need. And if in your community you can get people who are on CPAP talking to each other and providing support, and what the problems are, it's really what we need. And having someone of the same race and ethnicity making those suggestions rather than this guy with the white hair, I think makes a big difference. Now, the biggest thing is, if you all are working in hospitals, is getting that high-risk patient with congestive heart failure, severe asthma, COPD, obesity, making sure that they're directed on. Now, what we know about pulmonary rehabilitation is people recommend it, and we did a pretty aggressive program. I spent $4.5 million of CMS Innovations grant doing this, and we didn't have a pulmonary rehab program in place in my hospital, and they decided they didn't want to pay the retirement plan for the person who was in charge. So I got $100,000 worth of equipment and no human. And there was a 6-month backup in terms of the one in town. So it's hard enough to get people into pulmonary rehab programs. So spending that time during hospitalization to make sure that it includes thoughts about the sleep apnea, because the American Heart Association, as we'll talk a bit later, recognizes that's a problem with congestive heart failure. It's got to be a question. It's got to be a priority. I mean, I guess if I eat one hot dog, I lose 16 minutes of my life. Occasionally, it might be worth it. But in terms of a major health intervention that's going to improve your heart care, this is being a proactive screening in the hospital at time of discharge. So, and then the last is just this crossover study, 75 urban African-American adults who had both home sleep testing and laboratory polysomnography. 82% preferred the home sleep apnea testing because you could sleep in your own bed. I had a device, what year is this? So it's 2022, 2010. When did the Lehman Brothers go down? Around 2008. So this was the Vivometrics Life Shirt, and so I could do home sleep testing. It said, and it was nice black, has LIFESHIRT, and silver, looked like Michael Jackson. And so there's, I think it's still on the International Space Station, and I could see them without seeing them. Every breath you take, every move you make, I am watching you. And so I knew I had one radio person, and I swear she must have been a vampire because she would come straight up at night. Are you opening your coffin? What are you doing there? And she had a bad back and had to stretch it out, as it turns out. And I had one of my kids who is obese. He's 8 years old. And so I sent him home with a $100,000 prototype. And they moved. 3 days later, didn't return the device. I go, oh, this is good. So 3 months later, they moved back, and I got a call from the school. They said, Dr. Landon, what are you thinking? I go, what do you mean, what am I thinking? Well, you dispensed him with this vest, and it says life shit on there. Oh, pull it down. Oh, life shirt. Now we see it. So, but home sleep testing and home sleep intervention is really, I think, a better approach. Your sleep lab may not agree with that. And again, that's where using at least a screening device to get people into the right place. So this whole telemedicine and health informatics, which you'll hear about from Encore more and more, is how can we use things like artificial intelligence and really find these patients. Are you cursed with Cerner, or we call it, when you're burned out by Cerner, called incineration, so, or Epic, or any of them. You can start to pick out disease categories where they are at increased risk. You can pick out height, a BMI that puts them at increased risk. In terms of the follow-up, to find that 40 to 60% of people aren't using CPAP anymore, let's go see your CPAP machine. Let's dust it off. There, it's in your closet. And then the primary care physician being able to access the subspecialists. This is where education takes place. We do participate in, I forget what it stands for, the ECHO program. And with the ECHO program, you can present your patients to a specialist. And then the idea is that the primary care physician is being educated back as they discuss it. And we just did this for Kenya. And this man was selling bananas in front of the tent. Oh, that's interesting. Let's keep talking, though. And I'd say at least put it on mute while you're selling your bananas. So we can have really a global health outreach with telemedicine. Well, there it is. There's my Project Echo right there. So, and then the veterans, that's a different system from Medicare. So we have access to some things for veterans that I don't have elsewhere. And so I think you'll see some more aggressive. And then the Kaiser system. Are any of you with Kaiser? Or do they have Kaiser out here? Probably not. So Kaiser also understands that home sleep testing is the way to go. It's less expensive for them, and the eventual health effects are beneficial. So, just in general, in terms of health equity, hopefully this health information technology will decrease the digital divide, as every single person in the world has a a cell phone, but we still have the barriers of poverty, language, health literacy, just getting people to be able to read a bottle and knowing what's in there. But thank you, COVID, for increasing telemedicine. Okay, then pediatric sleep. I got to educate my pediatricians, and so they're not the ones that generally you're seeing in your sleep labs. So that's where, again, reminding them that they have children. Oh yeah, he snores just like his dad does. Not exactly what we're looking for, but it's also having sufficient sleep. Again, this stupid phone. Oh, Sally doesn't love Billy. Oh, Billy doesn't love Sally. Oh, and so I was talking to the Orange County coroner, and she said, Dr. Landon, what do you think about cell phones? I go, well, I'm not in favor of them. I take them away at 9 o'clock at night, and they get them back at 6, and they also have to earn cell phone time. And she said, well, I just had a little girl brought in, and 14, committed suicide. One of her classmates took a boyfriend app. I don't know if you girls don't listen. There's a boyfriend app which will call your girlfriend's cell phone and say, oh, you look so pretty today. I love what you're wearing. I can hardly wait to see you. And he hacked it into, nobody likes you. Everybody hates you. Kill yourself, kill yourself, kill yourself, kill yourself. And she killed herself. So it's not my favorite. And so that leads to the insufficient sleep. So they really need 8, sometimes 12 hours. And it all seems to happen on Saturday when we could use them to help clean the house. But again, my Latinos, my black inner city kids, it's a real problem between the noise and the light and all the social things that go on. So it's less efficient sleep. And with less efficient sleep, you need that deep sleep to clean out your lymphatics up in your brain. So I'm trying to avoid early onset Alzheimer's. Hopefully I'm on my way to avoiding it. So all those things, again, are associated with increased incidence of obstructive sleep apnea. So what can we do? Well, we have to intervene on all those things. And we have to do it at the level of the primary care physician and yourself and in your community and in your Rotary and in your Kiwanis and in your social organizations, really emphasizing that sleep health is important. And then moving it over to the primary care physicians away from, or in addition to, I guess, my sleep specialist. And again, the sleep specialist, I couldn't even get them to give me the right reading. If I had a child who is 6 years old, they go, oh yeah, they have severe sleep apnea. Their apnea-hypopnea index is 1.1, and it says 1. And I go, well, no, there's actually some age adjustment in there, so not everybody needs to go on CPAP. And they also are not the greatest at doing that. And then what we've seen, of course, is, I don't know what the number is now, 82% of America is depressed. We have no access to behavioral health interventions. But again, if you're anxious and you're not getting to sleep, you're having early morning awakenings, midnight awakenings, again, we just need better sleep hygiene. And that has to come from my physicians, but also from you as ambassadors. So this needs to happen in childcare. We need to educate them nice and early. Schools need to integrate this in. I spent a year getting cleaning materials. Oh, my school isn't clean unless it smells clean. I go, yeah, limonene will lead to obstructive sleep apnea because you're getting stuffy noses when these kids get home. So let's make this clean. It doesn't need to smell like a pine forest with artificial petrochemicals. But making sure again that the schools know, and that they're also informing the pediatricians if the kids are falling asleep mid-class. And then at-risk youth, and then I did 5 counties asthma education. So I have 60 providers who will listen to what I have to say, which is, might have saved my second marriage. And we actually would send pizzas out to this one, and I'd send them peak flow meters, and they would start to cry. They go, no drug rep has ever been in our town. So they appreciate that. So just in conclusion, sleep equity is important. And it looks like I have 2 minutes left. Yes. So let's talk a little bit about this circle plus ring. This is a central way for me to monitor my patients. So this it's able to do temperature, pulse, respiration, EKG, and for $300, to me it's best thing since sliced bread. I think we're waiting a little bit longer for Kaiser to get it in place, but you want to be able to see these patients, see them at home, give them access to home sleep testing, and maybe don't necessarily need flow, although for billing you do need that nasal flow at home. Okay, and then let's just talk a little bit about chronic illness and the remaining little bits here. So type 2 diabetes, and again associated with overweight, cardiovascular disease, obesity, depression, all associated with sleep disturbances. And that poor sleep will increase your development of type 2 diabetes. It'll predict your hemoglobin A1C, and if I can just optimize sleep, I can get hemoglobin A1C down without drugs. How amazing. So if we can improve blood sugar control through better sleep hygiene. Cardiovascular disease, again, the American Heart Association has finally figured this out, that you are at increased risk, and that particularly the problems with hypertension, coronary artery disease, and then cardiac arrhythmias are a problem. She's circling, isn't she? So there's our American Heart Association. They have a very nice, came out in 2022, I believe, the publication in March. And if you can educate your local physicians that obstructive sleep apnea is associated with difficulties with the heart. And of course, obesity in our communities. I think all of us are trying to prove, rethink your drink. If I've got 12 ounces of soda, gosh, if I have 12 ounces of water and I put in 22 packs of sugar from McDonald's in there, that's my Coca-Cola. So if we can just rethink our drink, if I can get places for people to walk and really have an awareness, not a shaming, but just an awareness, we want you to be healthy. And then depression. It's complex. If you're not sleeping well, you're anxious, then you're not going to sleep well, and if you're not sleeping well, then you're depressed during the day, and so it's a horrible circle. Okay. Whew. Yeah, I felt the hook here. Anyway, just hopefully you've learned and will retain a little bit about just morphology, the risk of sleep apnea, be my ambassadors for those children and adults, that health equity, that you return to community and really start thinking about the neighborhoods and access to care, and then also the patients with chronic illness. So thank you.
Thank you very much, Dr. Landon. We appreciate it.